বলছি এই মহারাষ্ট্র ব্যাপারটা বুঝলাম না।
কোনটা মহারাষ্ট্র?
ওই যে তুমি পাঠিয়েছো মহারাষ্ট্র একটা মিটিং, জুম মিটিং।
না না, ওইটা ওইখান থেকে করেছে বলে কি সৌভিক, দ্যাট হ্যাপেন্ড লাইক দ্যাট।
ওকে, এটা হেডকোয়ার্টার হওয়া উচিত ছিল না?
মহারাষ্ট্র কোথায় লেখা আছে? মুম্বাই, কলকাতা, নিউ দিল্লি।
মহারাষ্ট্র লেখা আছে।
না।
প্রথমে তো ঢোকার সময় হচ্ছে টাইম স্কেল অ্যানালিসিস বা টাইম সিরিজ অ্যানালিসিস ছিল।
হুম।
আর এখন তারপরেটা হচ্ছে, ও না, পেয়েছে মাস্টার ক্লাস মুম্বাই
মাস্টার।
কলকাতা নিউ দিল্লি। হ্যাঁ, মুম্বাই কলকাতা নিউ দিল্লি। চলো মাস্টার ক্লাস ওই প্রথম মাস্টার ক্লাসটা দেখা দিয়েছিল একবার।
হ্যাঁ, ওটা প্রথমে দেখা দিচ্ছে।
আহ,
ওটা রিমুভ হচ্ছে না কেন জানি না।
কৌশিকদা কখন স্টার্ট করবো বলবে? স্টার্ট
লেট
করতে
দা
বললে করবো।
ইয়ে
লেট দা
কোথায়
স্পিকার্স লেট
স্পিকার্স?
দা হ্যাঁ, লেট দা স্পিকার্স জয়েন।
ওকে।
ঠিক, স্পিকারদের ফোন করে নিন।
উইল কল দেম। কে করবে?
হ্যাঁ, আমি একজনকে করছি, তুমি ডক্টর অরুণ সিং কে করে নাও। আমি অমিতা
ওকে,
ম্যাডামকে করছি।
ঠিক আছে, আমি করে নিচ্ছি। কৌশিকদা,
Good
হ্যালো
evening, Sanjeev. Are you here?
হ্যালো।
Hello.
অরূপদা, কৌশিকদা is here or not?
Yes, I am here.
Yeah, I am audible.
Okay, you are audible. So I called Dr.
Yeah,
Arun
yeah.
Singh.
Okay, you
Sir,
start, then I'll continue.
sir
Yeah.
will join a few minutes later. Actually, he is on his way to home. So should I
Okay.
start?
Sir has told that Arun sir that he will join around 7:15.
Yeah. He is on his way to home. Dr. Mitra,
Yes.
Kaushik?
I think we should wait for 5 minutes because there are only 14 participants.
No, there are participants over YouTube also.
Okay. So should we start or not?
Just wait for two
Ma'am,
or three. You can start.
ma'am is here. Shangamitra
Yeah,
ma'am?
yeah, ma'am is there.
Sanghamitra ma'am is.
Yes,
Yes.
I'm here.
Okay, ma'am. Should we start or should we wait for 2 to 3 minutes?
What is the time? Yeah, we can wait for 2 to 3 minutes.
Okay,
uh,
okay, ma'am. So then we will start. Okay, ma'am.
Hello, Professor
Or
Amrita Roy.
Or probably, Dr.
Hello.
Sangeeta, you can give your opening remarks and all that till Kaushik gives and all that. Later on, people will
Yes, yes,
join.
yes.
Yes,
That will be
can
done. That will
That
be
will be
done.
done. That will be done.
So just 2 minutes, then we will start. Okay.
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 You
Okay.
prepare yourself and okay.
Yeah, I am ready, but I think we should wait for 2 minutes. Okay.
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 But 2 minutes, he will not reach home, na? He will
No, no, no,
reach
no.
home around 15 minutes. 15.
Yeah, I'm not saying not for that purpose, but let some other people join.
Okay. Okay.
Okay. Okay. Okay. So should we start, ma'am?
Yes, you can
Am I
start.
audible?
Yeah.
Okay. Okay. So, good evening, everybody. Welcome you all in this live webinar session on World Health Day evening, conducted by Indian Public Health Association and Indian Academy of Public Health. The theme of World Health Day 2025 is Healthy Beginnings, Hopeful Futures. And this auspicious day will kick off a year-long campaign on maternal and newborn health. This campaign, titled Healthy Beginnings, Hopeful Futures, will urge governments and other health community to ramp up efforts to end preventable maternal and women deaths and to prioritize women's longer-term health and well-being. But this task is very critical. Why I am saying this? It is very tragic, but if we go by the statistics, close to 300,000 women lost their life due to pregnancy and childbirth each year, while over 2 million babies die in their first month of life and 2 million more are stillborn. So that is roughly one preventable death in every 7 seconds. I am reiterating, my friends, one preventable death in every 7 seconds. So women and families everywhere need high quality care that supports them physically and emotionally before, during, and after birth. Because the health of the mothers and babies is the foundation of healthy families and communities, helping ensure hopeful futures for all of us. And to discuss all these issues, we have two eminent speakers amongst us. Professor Amita Roy, Principal, JMN Medical College, Kalyani, Nadia, West Bengal, and Professor Arun Kumar Singh, Professor, Institute of Health and Family Welfare, Government of West Bengal. He is a very renowned neonatologist. For smooth conduction of this webinar, I, Dr. Sanjeev Bandyopadhyay, Central Council member of Indian Public Health Association, and with me, Dr. Arup Chakraborty, Assistant Managing Editor, Indian Journal of Public Health, will moderate this session. And now over to Dr. Arup Chakraborty. Dr. Arup Chakraborty.
Okay, thank you, Dr. Sanjeev.
Thank you.
To begin with the today's program, that celebration of World Health Day by IPHA, Indian Public Health Association. So first of all, we welcome you all the audience, the members as well as non-members of our own organization in this today's evening talk show. So we have two eminent speaker, as Dr. Sanjeev has already mentioned. Before going to the main program, first of all, I want to ask our President, ma'am, Dr. Sanghamitra Ghosh, ma'am, to give you a welcome address to the August gathering. Ma'am, please.
Good evening, everybody, and welcome to today's session on World Health Day, which the theme is Healthy Beginnings and Hopeful Future. I welcome our two eminent speakers, Dr. Amita Roy and Dr. Arun Singh, and all the members and audiences. So today's World Health Day theme, Healthy Beginnings, Hopeful Futures, aptly emphasizes the foundational role of maternal and child health in shaping long-term population health outcomes. For India, this presents an opportunity to reflect on the progress and persisting challenges in achieving safe motherhood and ensuring child survival. India has witnessed measurable improvements in maternal and child health indicators over the past 2 decades. Flagship programs such as Janani Suraksha Yojana, Janani Shishu Suraksha Karyakram, Pradhan Mantri Surakshit Matritva Abhiyan, Poshan Abhiyan have contributed increased institutional deliveries, expanded antenatal coverage, and improved nutritional outcomes. The National Health Mission has played a pivotal role in decentralizing healthcare delivery and strengthening the primary healthcare system. However, from a public health standpoint, critical gaps remain. The maternal mortality ratio, MMR, currently 97 per 1 lakh live births. This is SRS 2020. And neonatal mortality rate, NMR, at 20 per 1,000 live births, are still above global targets. Interstate disparities, inadequate human resources, suboptimal quality of care, and social determinants such as poverty, gender inequality, and education continue to influence outcome adversely. A comprehensive strategy is required, one that integrates continuum of care across the reproductive, maternal, newborn, child, and adolescent health spectrum, emphasizes equity in access, and embeds rights-based approaches into healthcare delivery. Strengthening community engagement, ensuring respectful maternity care, and leveraging digital health tools for tracking and follow-up can enhance the impact ongoing interventions. For medical educators and public health professionals, this is a call to intensify focus on health system research, implementation science, and capacity building at all levels. Aligning policy with field realities and ensuring context-specific, evidence-based strategies will be crucial to realize vision of healthy beginnings, leading to hopeful futures for all mothers and children in India. With these words, I welcome you all to today's session. Thank you. Over to Arup.
Thank you, madam, for your welcome address. So, see, this year's the feature or slogan of IPHA World Health Days by the WHO is really very interesting and call of the day actually, because last 30-40 years we are working so much on MCH care, but still we have not achieved the goal yet. So we need to work very hard and very sincerely. Being a public health organizations like IPHA, we have also a very crucial role on that. So next, I am calling our Secretary General, Dr. Kaushik Mitra, to deliver his speech before going to the main program. Dr. Mitra, please.
Thank you, Dr. Arup Chakraborty. Good evening, everyone, our dear members, and those who are watching this program on Zoom as well as it's transmitted over YouTube. Good evening to you all. Please mute everyone. Just please,
Sorry,
just
please
mute.
mute.
Ma'am,
Please
please mute
mute.
yourself.
Mute. Otherwise, there's problem. Okay. Good evening to you all. Our President Madam, we have with us our Central Council member, Dr. Sanjeev Bandyopadhyay. We have our Managing Editor, Dr. Pritam Roy, our Assistant Managing Editor, Dr. Arup Chakraborty, and our Chairperson of Indian Academy of Public Health, Dr. Sunila Garg ma'am. So, and all other members who are watching over YouTube and Zoom. On April 7th every year, not only the world observes the World Health Day. It is a way to raise awareness of important challenges. Please mute yourself. And
Madam, can you
wait.
mute yourself? Hansheshwari
Dr.
madam.
wait.
Madam,
Hansheshwari.
Madam, please mute.
Please mute yourself.
Yeah.
On
Okay.
7th April each year, the world observes the World Health Day. It's a way to raise awareness of important health challenges and motivate the group efforts to address these challenges. To increase the awareness and drive worldwide action is being planned. This day is dedicated to certain health issues. It highlights the necessity of international collaboration in addressing the health issues and acts as a reminder of the significance of good health for general well-being. So every year there is a theme, and this is an effort to increase the awareness and inspire the global action. So this year the theme is the healthy beginnings and hopeful future. This will be the campaign all around the year, and it will ramp up efforts to end preventable maternal and newborn deaths. So every year we are teaching maternal and child health, but this year we are stressing more on preventing maternal and newborn health by using the theme healthy beginnings and hopeful futures. Women and families everywhere need high quality care that supports them physically, emotionally, before, during, and after birth. So there are health systems that may evolve or emerge to manage the many health issues that can impact the maternal health and the neonatal health. So taking this into consideration, we have two eminent speakers today, Dr. Amita Roy and Dr. Arun Kumar Singh, who will be delivering real insights on this very topic. To add to this topic today, on behalf of Indian Public Health Association, I would like to tell you that today on this auspicious day, that is on the World Health Day, we have released a joint statement along with other organizations like West Bengal Academy of Pediatrics, Neonatology Society of West Bengal, Bengal Obstetric and Gynecological Society, Association of Physicians of India, and Indian Association of Dermatologists, Venereologists, and Leprologists on triple elimination of vertical transmission of HIV, syphilis, and hepatitis B. I can share the joint statements on the screen. I think it's visible on the screen. This is the joint statement which has.
Yes, it's now visible.
Yes, it is visible.
Yeah, so
Yeah,
this
it
is the joint.
visible.
This is the joint statement that we have released on the triple elimination of vertical transmission of HIV, syphilis, and hepatitis B. It's an initiative in West Bengal by IPHA, WBAP, the NSWB, BOGS, API, and IADVL. And this has been prepared by, you can see, all the members of so many organizations together, led by our president, Dr. Sanghamitra Ghosh, myself, Dr. Pritam Roy, and Dr. Arnav Sarkar from our association. You can go through this joint statement. It's given in our website as well. So this is what we released today on this auspicious day of World Health Day. Now, I hand over you again back to Dr. Arup Chakraborty and Dr. Sanjeev Bandyopadhyay to continue this session. Thank you all.
Thank you, Dr. Kaushik. I just want to tell all the esteemed audience regarding this declaration of the joint statement regarding triple elimination. We have with us Dr. Pritam Rai. He is the WHO consultant of neglected tropical disease, as well as he is the managing editor of Indian Journal of Public Health. Before going to Amita ma'am, I just want a few words from Dr. Rai regarding this triple elimination joint statement.
As a member of Indian Public Health Association, one of the leading public health association of the country, it's our privilege to have this session today. And I would just quickly, in few minutes, would like to share a quick update on this triple elimination strategy, where the West Bengal State AIDS Prevention Control Society, the State Viral Hepatitis Management Unit, the RCH unit, the WJC Foundation, WHO, and all the professional association has come together to make stakeholder advocacy and political focus, leading to a pilot of strategies in West Bengal, where the program has been implemented. And there are a lot of policy changes has been brought about, especially in the syphilis treatment, which has been expanded. There was decentralization of delivery of HIV and hepatitis B positive pregnant women, and it has expanded to block level. There were mandating the dual HIV, syphilis, and hepatitis B testing kits, including at the screening points, including the labor room. All the at-risk persons were included in the retesting strategies. And there were protocols has been specifically developed, especially those in which we are lacking, especially the managing syphilis exposed infants at SNUs and prioritization of viral role. There has been a lot of training modules has also been developed, and healthcare providers has been trained. Materials has been developed for integrated flows and screening of management. There is a system has been developed, tool for developing and operationalizing this, tracking each and every person, all the risk omen who are these, and there has been roles and responsibilities has been defined. We have a state task force and block level review meetings, and this has been included in the agenda of public health meetings also. So we in 2023, we had this Kolkata commitment of elimination of vertical transmission of HIV, syphilis, and hepatitis. And we keep on continuing to do good work, and IPHA is playing a crucial role in this. So along this, on this eve of World Health Day, we have released this joint statement on the triple elimination of vertical transmission of this HIV, syphilis, hepatitis B, which is an initiative of the West Bengal, not only in India, but is a demonstration in the Southeast Asia also. So on behalf of IPHA, we are privileged to be part of this, and we are actively contributing in this. Thank you for this opportunity to update this. And I would also like to thank Dr. Arnab Sarkar for making this presentation. Thank you.
Thank you, Dr. Rai. We have kept this small discussion on triple elimination because this topic is very pertinent to today's WHO theme of World Health Day of this year. So now it is a time to go to the main topic and main presentation with our two eminent speaker. So we have with us Professor Dr. Amita Roy, Madam in Gynecology, and the fellow in Gynecology, Oncology, Royal Academy of South Australia. She is a fellow foundation is FIMER from PSG Coimbatore and Masters in Health Professionals Education MHPE. Currently, she's the principal of JMN Medical College.
আমাদের each payment 40 rupees এবং অন্যান্য যে কোনো leading bank
She has- Can you mute yourself? Yeah. Currently, she is the principal of JMN Medical College. She has worked as a clinician and medical teacher in various medical colleges all over India for past 20 years. She has also worked in UK, Australia, and Oman. She is very passionate about her work among underprivileged women with pregnancy complications and genital tract cancer in tribal and rural areas. She is an advanced trauma life support educator for India, Middle East, and Southeast Asia. She has trained several specialists and postgraduate doctors in India and abroad in trauma and critical care. She is equally passionate about medical education. She has introduced several innovative projects in health education, which have improved medical teacher efficiency in resource-constrained setting as a part of her PIMA fellowship. She has guided several postgraduate dissertation as well. Madam Amita has several publications in reputed national and international journals, including British, American, and South Asian journals of obstetrics and gynecology. She has authored and co-authored of several book chapters in obstetrics and gynecology textbook used as a part of undergraduate and postgraduate education in our country. So with this brief description, I'd request ma'am to begin the presentation to our esteemed audience. Thank you, ma'am. Over to you.
Thank you very much for this introduction. And at the outset, am I heard?
Yes,
You are audible, ma'am.
Thank you so much. So begin with heartfelt thanks to the organization for giving me this opportunity to speak on a subject which is very close to my heart. And I thank you for this brief introduction. And should I start sharing my screen if I can?
Yes, sure.
Just a second. Just bear with me and just show it. Is the screen visible to all, please?
Yeah, ma'am, it is visible, but please share the screen in the
Yes.
presentation mode.
Yes, yes.
Yeah.
Is it okay?
Yeah, it's perfect.
Okay. Thank you. Perfect. So once again, thank you to all of you for all of those who have joined today. Let me begin with today's topic. And this is a topic which has been given to us on this World Health Day by the WHO, namely healthy beginnings to hopeful future. 4 key words make up this message. So health, beginning, hope, and future. We all know the definition of health. It's well-being in body, mind, and as well as a social well-being. Beginning, a synonym can be taken as initiation. Hope, ironically, something that we all live for. And future, nobody has seen it, but all of us work towards trying to make it better. So from these key words, on to the key messages. So the key message says, beginning healthier. It's not that we are not healthy, but the aim is to make it healthier. And why? So that the future is hopeful. And hopeful for whom? For the individual, for the family, for the society, for the nation, and subsequently for the whole universe, for whole of our world. Now, if you look, the concept is not new. If you look at ancient Indian scriptures, and I looked it up, it said, if we want stability in our family, society, nation, we need to have stability in the individual. So same way, if we need to have a healthier world, a healthier nation, a healthier society, and healthier family, we need to look at the health of the individual. So going with this, let us ask ourselves, where does health begin? Well, the straight, simple answer is where life begins. Where life begins, health begins there itself. And where does life begin? And in that sense, if we look at health, we can say that the uterine environment is critical in shaping long-term health outcomes of the newborn and the individual. Now, let me stress on this word long-term health outcomes. It's not the immediate outcomes, cerebral palsy, mental retardation, etc. Now we all know that Mr. Baker, who gave us the Baker's theory of diseases initiation in the womb, has proved to be right, that even long-term implications or diseases that are plaguing the world today, diabetes, hypertension, take all their origin in the womb itself. And we gynecologists go a little further on, and we say it also depends on the health of the ova and the sperm. So if we look at it that way, the ova and the sperm also would be healthy if the individual is healthy. So with that beginning, I would like to go on to what we are supposed to do today, and that is to dwell on, to think about, to find out ways of trying to emulate the slogan that is given by the WHO for this World Health Day, that a healthier beginning will lead to a hopeful future. Provided the beginning is healthy, there is strong hope for a good future. I'll divide my talk or all my slides into two parts. One part on the left will give you the key messages from WHO. And the one on the right will try to analyze where India stands. So WHO has given us a roadmap with some milestones in it.
Hello.
Hello? Sorry? Am I audible to everyone? Is there any problem?
Yes, ma'am, you're audible.
Yeah.
Okay. Shall I continue?
Yes, ma'am. Can continue.
Okay. So the key messages that the WHO has given us on this World Health Day and where India stands as regards these key messages. What could we do? Where we are now and where we have to go? What could we do to travel and reach that destination towards which the World Health Organization has pointed by the key messages today? So first, let's talk about what are the key messages that WHO has given us. And these messages are not for us only. By us, I mean the healthcare givers. It is for several people combined. Why? Because health and medical science and healthcare science is not a pure science. It's a totally a social science. And we have to take society along with us. And in that society, we have various people who can contribute immensely to health. So let's divide for organization this into the key messages into 4 domains, or rather 4 key people to whom these messages should go. So for the policymakers, can we cut out the disturbance, please? Okay. So for the policymakers, for the pregnant woman, for parents and caregivers, and when I say caregivers, this includes the whole of the family, and for the general public per se. So let's read what are these messages. So for the policymaker, WHO says, end preventable death. That, of course, is the first goal. Mortality to be prevented, but there's a lot of morbidity too. So the next thing it says is high impact investment. Policymakers should invest where or in such areas which would have a high impact on the health of the mother and subsequently the individual or who is there in the mother's womb. Next, it talks about beyond survival. And that is where we talk about the morbidity part of it. It's not enough to survive. It has to be a healthy survival. Otherwise, where is the hope? And then it says about improving women and girl rights. So these were for the policymakers. For the pregnant women, it divides its message into 2 parts. It's during pregnancy and after childbirth. For the parents and caregivers, it talks about caring for the newborn. And I think it includes the mother as well. And the next part of it is quite important, although doesn't result in an individual who could be given a hopeful future. But nevertheless, it's very important, and we'll come to that, and that is support during miscarriage. So after a miscarriage, there are a lot of issues which needs to be addressed. And last but not the least, for the general public, one singular word, and that is support. Now, each of these, if we start discussing and talking about, would take hours, but I'll try to do justice in these few minutes that are given to me. So let's start with the policymakers and see about these 4 points: end preventable deaths, high impact investments, beyond survival, improving women and girls' rights. So let's take end preventable deaths. Now, what is WHO talking about? It is talking about achieving targets. So subsequent or the previous World Health Days, a lot of targets were given, important health indicators, sustainable developmental goals had been given. These were the WHO target. Where are we? Where is India on the roadmap? Well, as was said earlier by Dr. Sanghamitra, that a lot has been done. Maternal mortality, infant mortality have decreased both state-wise and in the country as a whole, as per our survey data. But is that enough? Well, the answer is no, because there are still countries which have a much, much lower mortality as regards these 2 data. So a lot to go ahead. Next, coming to a very interesting thing, investing in human capital. And just let me read it. It's quite interesting. It says, in low and middle income countries, every US dollar, that means $1 invested in a maternal and newborn health is estimated to yield around 9 to 20 US in return to the exchequer. Well, I cannot say anything about that as regards India, but if that can happen in one country, maybe we should start generating data, convince our policymakers that it is so. And it's not very difficult to understand that if a pregnant woman, a working woman, enjoys good health and after delivery returns to work timely, she does contribute to the economy of the country. That's what my small economic sense tells me. I leave it to you to understand the rest of it. Third point, no one left behind. Now, what does that mean? So the WHO says wars, conflicts, natural disasters are fragile settings which have the highest concentrations of maternal and newborn deaths. Well, again, here in India, we do not have such data, but we don't have to look too far. We are seeing the world at war at large, and every day when you open your TV or you look at your mobiles, you will see this kind of information pouring in. The worst hit, the mothers and the newborns. Right. Going on to the next message. Investments that have a high impact on health. And what are they as per WHO? Antenatal checks, life-saving care during and after birth, immediate newborn care, special attention to vulnerable babies, focus on midwives, and access to family planning. Now let us see where we are, right? And in this regard, I'm going to deal with, sorry, just a second. I'm going to deal with the last 2 points a bit more elaborately because India has several issues here. And all the other points, that is 4 of these points, I'm going to take together as to what is happening in India. Well, on the right side, you can see what you probably already have seen number of times, and that is the NFHS data. That is the 4th one and the 5th one and a comparison. And although verbatim the things are not same, but we also talk about, and what do we talk about? Pregnancy registration, 4 or more antenatal visits, institutional deliveries, all those things that are talked about in the first 4 points here. So we have shown improvement. But again, we must remind ourselves that more improvement is desirable. Now let me come to these 2 points at the end. Focus on midwives and access to family planning. So what is happening in India as regards this point? Midwifery in India. Well, we are still in our infancy as regards midwifery services. Now, on your right, you can see a charter which has been prepared, and this is 2018. It talks about guidelines on midwifery services, and quoting from this book or these guidelines, I'll just give you 2 statements. So the government of India has taken a landmark policy decision to roll out midwifery services in India. So midwifery services in India probably before this were equivalent to non-existent. And the next statement, bringing midwifery services to center stage will help improve care. So although we've started late, the realization has come, and this is where probably Indian healthcare givers need to work more. So midwifery in India has yet to take center stage. There is no special empowerment programs for midwives. Maybe my nursing colleagues here who may have joined may know about it. And if they know about it, they should make it more explicit. There are at least one thing I'm not sure of, that there are no midwifery units in medical colleges.
একটু টয়লেটে এটা দেখিয়ে নাও তো আমাকে কোনটা কি সুইচ অন আছে নাকি
And
সুইচ গুলো দেখতে পাচ্ছি না
sorry,
Rama madam, can you mute yourself? Yeah. Ma'am, please continue.
Thank you. So if you look at these 3 points, yet not center stage, no special empowerment programs for midwives, no midwifery units in medical college, India has to go along. Now let us come to another thing, and that is access to family planning. Now, do you think accept translates into acceptability? I doubt it. The policymakers may have made access or availability, but is acceptability? We need to ask ourselves this question. Access has increased. Availability, rather, I say, had increased. But has the acceptability? There have been lots of studies on knowledge, attitude, and practices on this subject of family planning, contraception, this, that. Any data about the implications of these studies? Any conclusions? Any actions taken to address these concerns? Why I ask these questions is that access does not translate to acceptability. There have to be special measures, there have to be different measures to increase acceptability. One may be awareness and education. There may be many more which we need to think about. Let me come to the third one, or the third message, and that is beyond survival. So what does the WHO say? It talks about compassionate, respectful care and postnatal support, family-friendly policies, and empowering girls and women. I'll take the two together and I'll talk about it in the Indian scenario. Compassionate and respectful care. Who will give it? A person who has correct attitude, isn't it? So there has to be an attitudinal change on the part of the doctors, the nurses, and of course, midwives when they eventually come. Because it's very important that this compassionate and respectful care be given. Otherwise, why should they come to the healthcare givers to have checkups or have a delivery conducted by them? And in that context, I would like to say, and all of you probably know, that a holistic attitudinal change has been targeted through the ATCOM modules in the CBME program. So what we need to do, but actually there is still many things to do. Again, these ATCOM modules should not remain on paper. They should be implemented. And students or forthcoming caregivers should understand why it is so and should implement that. Next, let us come to family-friendly policies and empowering girls and women. Now, recently, or I should not say very recently, but relatively recently, till recently, we used to follow the partogram to monitor labor, to monitor the child, to monitor the fetus, to monitor the mother, to monitor the progress of labor. But WHO has now given a labor care guide. And what are the changes from the partogram to the guide? The changes are mainly in these two domains: family-friendly policy and empowering the laboring woman. And how? It says in the first page itself that you should allow somebody to be there present in the delivery room with the lady to give her emotional support. It may be a relative, it may be her friend, it may be her husband. I know we are very afraid of infection, etc. But if WHO has said that, there must be some substance in that. And personally speaking, I have also gone through labor. And many of my lady friends have gone through labor. How much emotional support is required during that time? I think they have had it firsthand. They've understood it firsthand. So nothing more to add to it. And when we talk about empowering girls and women, I should think this empowerment should begin from girls. School curriculum should include health education, which sadly it does not. And it should include education about hygiene and reproductive education. We try to shy away from this. Why? Because if we shy away from this, these girls in this world, in this age of internet and God alone knows so many networking things, will get the wrong information. That is much more harmful than getting no information at all. So empowering girls and women, I think school curriculum should be encouraged to have some amount of hygiene and reproductive education given to these girls in an appropriate way. So let me move further. Same way, let us talk about women and girls' rights. Improving, and WHO says, improving the rights of women and girls. And how should that work? That should work by empowering them to protect their own health. At least give them the power to protect their own health. Now, here I would like to say, and all of you know, that India is one of the first countries to give the women right to abortion. And subsequently, this MTP Act has undergone several changes which are all woman friendly. And we should be proud of that because many countries don't have it. But is that all? Should we stop at that? Well, let me see. So what more do we require? So why have these pregnancies? Why have these MTPs? So minimizing unwanted pregnancies is what we need to somehow work towards. And how we do that? Educating women and girls how to avoid unwanted pregnancy. Making them understand that contraception is better than undergoing an abortion, even though now abortion is just medical management. It's not surgical management. Even then, it is better to adopt a contraception if they don't want a pregnancy rather than undergoing abortion. Emphasizing about the advantages of contraceptive methods and suggesting ways to minimize the side effects. And again, I would reiterate that parts of this education should start in school. Health education, reproductive education should become an essential part of a school curriculum at an appropriate class, at the appropriate time, in the appropriate way, that many educators can sit and talk about that. And more importantly, remove this stigmata or the stigma associated with the word abortion. Why do we have to have this stigma? Why do we have to speak in low tones when we talk about abortions? This is the stigma. Right. This brings me to end for the messages to the policymakers. Now I come with the messages that the WHO talks about for the pregnant women. Simple. During birth and after birth. So let's see. WHO targets these things, that women should seek care. Important tests should be done during the antenatal period. All tips about staying healthy should be done to them, should be given to them. Warning signs about dreaded conditions, eclampsia, preeclampsia, anemia, whatever, should be told to them. Doctors should take that time. And baby movements, how they should monitor, that should be also explained. Let's look at India. What is happening here? So our National Medical Council has introduced the competency-based medical education. And they have put antenatal care as a must-know competency, a very welcome step. But what remains? The implementation, which is again in the hands of us educators, and which we must do if we want to achieve these targets. Similarly, midwifery and obstetric nursing curriculums should also be designed with competencies which empower them to do all this that the doctors are doing, because we face a dearth of healthcare givers, true healthcare givers, dedicated healthcare givers. Now, seeking care. Why I put it in a wavy line? Because I want to talk a little bit about it in the next slide. Again, the same thing. Seeking healthcare patterns. How, why, when does a pregnant lady seek healthcare? We need to understand that. And again, I would like to reiterate the same thing. Healthcare availability is not the only answer to improve health in societies. We must study the pattern of healthcare seeking. With facilities available, if individuals do not use them, healthcare programs and initiatives are bound to fail. Now, let me talk a little bit about what solutions we could offer. Is it logistics? Is the healthcare facility too far away from homes? Are there time constraints? Should there be doorstep availabilities, and how well they are managed? Manpower, education, involvement, all of this could offer solutions, which we need to sort out amongst ourselves. So program success needs these three components: availability, yes; accessibility, yes; and acceptability. Any one of them missing, a program is not going to succeed. And we know how many healthcare programs have been launched by central government, by the West Bengal government. So we must ensure that the success of these programs we should keep it in mind. The success of these programs will depend upon these three A's. Now, what happens after birth? So WHO targets that after.
Ma'am,
Sorry.
I just want to interrupt you 1 second. So
Please.
can we conclude within 2-3 minutes? Is it okay?
Yes, sure. So
Thank you.
WHO targets physical recovery, emotional changes, bonding with your baby, and postnatal checkups, warning signs, and mental health. Now, I won't go to the first ones I'll take it holistically, and I'll draw your attention to the last point. Counseling session for new mothers by interdisciplinary team is very important. Obstetrician, pediatrician, psychologist, physiotherapist. Very important to have this. And this is the era of interprofessional and interdisciplinary collaboration. Multidisciplinary team to address postnatal care. For parents and caregivers, two things: caring for the newborn and support during miscarriage. Now, caring for the newborn, I am not going to talk about, because our esteemed speaker after this is definitely going to have a lot to talk about this. I'll just talk a little about support during miscarriage. Now, a multidisciplinary team to counsel the patient and plan for a future pregnancy with family and friends support is what is needed. Said in a very 1 second, in a very small sentence, but packs a lot of power in that. For the general public, support. And how? These are just few suggestions. I think there can be n number more. Spreading of awareness, networking, participating in authentic educational programs, sharing personal experiences, reporting domestic violence, reporting child abuse, and ensuring children attend school and don't do labor or work, which often happens. For our part, we healthcare givers have to ensure correct awareness, appropriate messages, established guidelines, and evidence-based information. Not all information on WhatsApp may be correct. So this is what we have to work for if we want the general public to make a revolutionary change. Just to summarize, what has been done? A lot has been done. What needs to be done? Looking back to see the effectivity of what was done, and looking forward to see what new measures are to be taken further. Pandora's box. Hope is the brightest star. With hate, anger, poverty, and ill health, all should be surpassed by this hope. That's what probably the WHO hoped when they were giving this message. Thank you, and wish you all a good health and a hopeful future.
Thank you, ma'am. Thank you for your so yes, you have correctly mentioned that we require facility based as well as a community based care to improve our maternal nowadays midwifery led delivery points. I think we have in our state one setup in NRS Medical College where we have a midwifery-led delivery setup, and the things are also progressing. And also you have mentioned between the relationship of medical education as health services to improve the maternal care. So with this note, I'll also I once thank our esteemed Madam from JN. Now I want to introduce the second speaker of today's evening. Professor Dr. Arun Singh. I think most of you have already heard his name. Sir actually is a professor of neonatology, an academician, an innovator, and a programmatic researcher and a public health book. He developed the concept of sick newborn care unit for the first time globally and demonstrated it at Purulia District Hospital, West Bengal, India. This was supported with multiple international papers, including Lancet. This model, called Purulia model, was replicated in all the districts of our country. As a national advisor, conceptualized the concept of childhood screening and of more than 40 diseases for every child from birth to 18 years, called RBSK, that is the Rashtriya Bal Swasthya Karyakram, under Ministry of Health, Government of India, and he was also instrumental in its implementation and wrote more than 15 training manuals, including Journey of First 1,000 Days. Apart from SNCU, Sarah started the first Institute of Neonatology with Modern Investment Bank, first in the country, Genetics Laboratory, Neonatology, Neurodevelopmental and Early Intervention Unit. He has advisor to state government and is currently working as a professor at West Bengal. Publications with about 50 in the international journals. With this small note, I want to introduce and call Arun
Yeah. Am I audible?
Sir
Uh,
to deliver next week.
yeah. Am I audible?
Regarding his work. Sir, your voice is breaking.
I said, am I audible? Hello?
Yes, sir, you are audible.
Now you're audible.
Okay, okay. Just thank you very much for this opportunity. I'm trying to share my slides. Is it visible?
Yes, sir.
Okay. So thank you very much. And taking from the last speaker that the return of investment is highest.
Sir, this is not in the presentation mode, sir.
It's not in presentation mode.
Yeah.
Is it coming as slide?
Yeah.
Is it better? I don't know if I.
Yeah.
Can it be seen now?
Sir, can you put it in this presentation mode? It's better than before.
Yeah, the problem is in. Let me see if it comes in. Is it coming in the presentation mode?
Not yet, sir.
Actually, with Zoom, sometimes there's a problem.
Yeah. Okay, you continue, sir. No problem. You can able to visualize.
No. If you are able to visualize, what I will do is, I will increase the size. Is it okay now?
Yeah. It's
Okay.
better.
So, thank you very much. Taking note from the last speaker, the return of investment is highest if you invest in fetal and newborn life. This statement was made. This statement was made by a Nobel laureate called Heckman, which he showed that after the age of 18 years, the investment is very less. So for any country to even grow economically, they should not consider investment in fetal and newborn and toddler life as an added cost. but it should be included. It should be thought as an investment. My second point is that in a country of 1.45 billion, where we have a huge cohort, we always thought that population is a problem because so many people, that means so many mouths to feed. But if you turn the thought process and consider each member of the population to have about 100 billion neurons, and if you consider that the power of the brain is far more powerful than the material power, then today's discussion is, can we develop this power of the brain? Anyway, in the Battle of Palasi, we have seen that though Bengal had all the wealth you can think of, it was one of the richest cities of the world, yet we lost our independence because we had material power, but we did not have the knowledge power of James Watt when he was creating the steam engine. So when I say healthy beginning and hopeful future, the future is not a city of diamonds and gold. The future is a city of a cognitive population. And the healthy beginning does not start with conception. The healthy beginning starts even prior to conception. You become a mother or a father not when you conceive, especially the mother. You become a parent the day you think of becoming a father or mother. So when we consider this topic of healthy beginning and hopeful future, we are talking about a pre-conception period just after marriage. We are talking about conception. We are talking about antenatal period. We are talking about the delivery place and the delivery process. We are talking about the post-delivery, the first 2 years when the neuronal formation is at its best, and the first 6 years when 90% of the brain gets formed. This entire topic.
Sir, just sorry to interrupt you. Are you
Please.
changing your slides?
No, I'm not changing my slides.
Okay, then it's fine. Yeah.
So this entire science has been broken up by our medical fraternity into bits and pieces. And these are being funded by the insurance. So instead of having an assured health, we are having an insured health where each department is held by a different person, but the baby is the same. So when you think today of the fetus which is today, 9 months later, it will come out. But now the caregiver is getting changed. The science is getting changed from an obstetrician to a neonatologist. After 28 days, the baby remains the same, but will not take care of the pediatrician. And hence, I propose to evening that all of you think about a science in which this entire process should be taken as one, because it deals with a child, a Homo sapien, and a Homo sapien is neither known by its height or weight or its beauty. It is known by the brain, the 100 billion neurons, which gets formed by 40 weeks. So I begin to propose, can any one of us think of bringing all these sciences together and let this be called perinatology, because peri means around and natology means the birth. So what am I trying to propose? Let's say a child who is going to school, the parents find the child has autistic, or the child has ADHD, or the child has some kind of a mental retardation. For that parent, the entire dream has shattered. And we today are no wiser because each of the component has been taken care by someone else and this compilation has not been done. So with these words, let me go to my next slide. That this perinatology which I propose is Can you see the next slide? Is the next slide visible?
Yeah.
Please. So this consists of preconception, prenatal, birth and newborn, infancy and toddler, and preschool. And why do I go up to preschool? Because, as I told you, the birth of a baby is a dream to a mother. Mere survival means nothing. It requires, every mother dreams that my child cognitively will do much better than I did in my life. And that is why this 100 billion neurons and its neuronal corrections is so important being a Homo sapien. Now, the most sensitive period of the birth defect occurs between 3rd to 8th week. Why is this important? Because by the time a mother comes to know that she is pregnant, the most sensitive period, the period in which all the organs are getting formed, the period in which your radiation, alcohol, drugs, smoking, German measles, lead, mercury, all kinds of poisonings can impact. Even diabetes can impact. This period, the mother does not know that she is pregnant. So obviously, she will not go to anyone to ask for help, because by the time she comes to know that she is pregnant, this critical period has already passed. So I propose that we should now shift to a preconception clinic, because that is the time when the baby has not yet arrived, but you are getting prepared. One of the most important things with global warming, that environmental temperature, research has shown, when a poor mother is working in the heat and she is going to spend the first trimester next to both external and internal heat, this has been shown to impact the ATP, the mitochondria, which is responsible for producing the ATP for the baby. So, though the West calls it that you should not take a sauna bath, you should not be very hot. If you have a temperature, you should take an antipyretic. But what about the sensitivity of the society that this extra heat? So my only message is, please tell that if a mother is cooking, the direct heat should not fall on her abdomen in the first trimester. And secondly, if she is a worker, she should be rested when the sun is just above her head, and she should be offered some. So these migrant laborers, they should be taken care, especially if the first trimester is in the summer months. And I did some research which showed that we actually extracted the mitochondria and did find the impact of heat on it. So just to say that on the day of the marriage, we should give a card to each of the couple and say that the birth of a child should not be an accident. You should plan it. So you decide when you want to have a child. And when you are preparing, think about your financial benefits. Think about whether you have the time. Do you have a career? Are you taking exam? Because the baby is going to require a time. How many babies do you want? What is your planning? What are the risks with increased age? All should be told. So you should be mentally and physically prepared, changes in the lifestyle. And 3 things I propose that should be in the preconception clinic, where you do not require a doctor. Number 1, check the blood pressure of both the couples. Number 2, check the blood sugar by a plain glucometer of both the couples. And the 3rd, at least the thyroid of the mother. And the 4th, tell her about the dietary advice, tell her about the folic acid need, and tell her about the lifestyle changes and mental preparation. If we can do this, today we should also talk of Dr. Subhash Mukherjee. We keep on talking about IVF, but this country missed a Nobel laureate, and this is what he was going to talk about. But he was of a clear-cut opinion that IVF should not become a routine thing. IVF should be done in a government setup with extreme degree of precaution and only after all other measures have failed. So, in his personal note, one of the days when he was doing teaching, he said the commonest cause of infertility is the stress. What you are seeing on the screen is drawn by his own handwriting, and this was published by the ICMR Institute from Bombay, where he's showing how stress and how dietary pattern is leading to PCOD and infertility. This only reminds me the true laboratory is the mind, where behind illusions we uncover the laws of truth. Now, if there is one message I would like to give to everyone, is that we are all aware of nutrition leading to problems of IUGR baby or low birth weight baby, but maternal stress can account for 30% of the preterm deliveries. This maternal stress is so important that the message should be given is, don't quarrel with a pregnant woman even if she makes a mistake, because you're not going to rebuke her, you are going to rebuke the child inside her. And not only it leads to preterm births, but it doubles the risk of behavioral problems in both boys and girls. So even if we are educated, are we sensitive to the needs of the baby? That even if we debate and produce a maternal stress, if the mother is a doctor, she is working in a hospital, we should take extra precaution that even if she makes a mistake, we need not give her any stress. The next is the intrauterine environment is one of the best. This kind of environment, the best neonatological lab, the best neonatology and ICU has not been able to do. So we should try to preserve and honor this intrauterine environment and not be in a hurry to deliver the baby. One of the things which is very important physiologically is that during pregnancy, if the mother takes some food, let's say green vegetables or some nutritive foods, which is good for the baby and also good for the mother, then the baby inside the mother's womb also gets this smell. And that is the time the limbic system is getting formed. And when it gets formed, then the baby slowly gets emotionally linked to this. And once it gets linked to this, there is a much higher chance that the baby will take healthy food. So this is just on the flip side, that if pregnant mothers are eating fast food during pregnancy, there is every chance that your baby may not eat healthy food. We were hearing from the last speaker that she said very nicely that we require a holistic view and interdepartmental collaboration for the success. And I think pregnancy and child really requires a department which touches everyone. And one of the things which is very, very important is oral hygiene. So if the mother has caries during pregnancy, there's 45 to 65% more chance of having a preterm birth. And when I say preterm birth, it's not only that your NICU stay is prolonged, it also would impact your cognition, which is, again, as I said, the representative of our of being a Homo sapien. So up till now, I made 7 points. avoid maternal stress during the antenatal period. It accounts for 30% of preterm birth. Maintain oral hygiene. Use concept of flavor bridge. That means if the mother eats green vegetables, the child develops a flavor of it. Interact with fetus, especially during the last trimester. The fetus has all the sensory organs which you and I have, and such interactions help in learning languages. Avoid infection by washing hands. All the green vegetables which you get, the fruits which you get from the market, put them into hot saline water or white vinegar for 1 hour and then discard the water. This would remove the pesticide and the coloring matter which is there before cutting it, and finally take the food well cooked. The most important point I was going to miss is that term is not 37 weeks, because this term of 37-week concept is not based on any sound research work. Traditionally, it only was based on lung maturity. But as a Homo sapien, we are far more worried about the brain maturity. Within 40 weeks, about 100 billion neurons are formed. That means every minute, 250,000 neurons are formed. So if you take away 1 or 2 weeks earlier, you are literally limiting the capability of the child. The Americans, after doing a wonderful study in which they followed up all children who were born between 37 to 39 weeks versus 39 to 41 weeks, they found that individuals born between 39 to 41 weeks, they had a healthier life, they had a better cognitive life, and they were less requirement of hospitalized or going to a doctor. After this, they did some changes in the definition. They said 39 to 41 weeks is full term. Then why do you talk of 37 to 39 weeks? The brain is not yet formed. So they said, okay, let it be called early term. I just would like that this message should go to every mother in our country. Please do not stop the brain development and allow the pregnancy to complete 39 weeks, as maturity of brain is only gets completed by 39 weeks. There is one more dogma which we have. We the doctors understand everything about child and labor. I beg to differ. There's a beautiful paper in which it showed that the design of a labor room, imagine getting a civil engineer and trying to talk to him that the design of a labor room can reduce C-section, can reduce the experience, can improve the experience of the labor and birth, can actually reduce birth asphyxia. How is it possible? This is a paper of impacting of birthing room design on maternal childbirth experience. Now, all this information would look a very, very technocratic environment. But let me tell you, basically, this mistake which we think is because we have a dogma that delivery, you require to understand the uterus and the ovary. Friends, delivery is not done from the uterus and ovary. Delivery is done from the brain. Most of the hormones from the posterior pituitary, oxytocin, vasopressin, prolactin, estrogen, progesterone, FSH, LH, all are produced from the pituitary, which are under the control of the hypothalamus, and the hypothalamus is in control of the ambience. So if a mother does not relax, normal delivery will stop. If a mother stresses, then there is going to be preterm delivery. So designing the labor room for the mother is an art which needs to be understood. The current scenario of the labor rooms are moving stages of labor. This we borrowed from our East India Company, which is basically a colonial past. Because even in their country, they don't use this design. Now in this design, we say for each stage of labor and finally for the delivery, there's going to be a different room. So each time it's like alighting a train and then getting down, then again alighting, then again getting down, and this process. Now this makes it very, very difficult and the whole labor process very, very chaotic. So when I was with the Ministry and Government of India, I advocated that we should have one room which should take care of labor, delivery, recovery room. They said India is a poor country, and I beg to differ. Our poverty is of knowledge, not so much of money. And what is that knowledge? That the delivery room can impact the cognition of the child. The delivery room, if the mother relaxes, there's much better chance of a smooth transition of labor. So birth companion, privacy of the labor room, all the stages happening in one, all this gives more comfort to the mother, which is necessary. This is a beautiful paper which says that if you need to reduce the labor pain, if you need to tell, please don't, you tell the mother, push, push, push. All this is not done in other mammals. Why should it be done in human beings? So this is a paper which showed that if you create a darkness in the room of the labor process, the melatonin is secreted, which stimulates oxytocin. If you keep the mother walking, if there is a underwater bath, if there is darkness, all this helps beta endorphins and better delivery with lesser pain. But if there is fear, there is cold, there is stress, there is hunger, the mother is lying on a top table, on a steel table, what we call the birthing table, all this gives her pain and stress. And all this will stop the normal labor process and release more adrenaline, which will cause pain. So this is not a theoretical topic. I went to Konark Temple and tried to see in the 13th century how delivery was taking place. So these are the figures of the Konark Temple, and I saw that the mother would sit and deliver. She would have birth companions. They didn't have a moving stages of labor. Even UK doesn't have it. And post-delivery, the mother would abduct her thighs and there was a fire-like heat being given, something very similar to the sitz bath. So we designed a chair with a cut and we put a fan and Philips infrared light. And we found that the breast milk got improved. There was 70% reduction in perinatal infection and the mother was feeling much more happier. So this is in a tribal village in Gujarat. I did my designing and then we designed a much better. This is like an LDR. The TV shows all the stages of the labor in the local language. If the mother wants to listen to music, she can listen. There's a birthing ball. So the mere getting the midwifery is not important. What is important is that the midwifery must start thinking about the mother, must understand the physiology much better, that if the mother is upright, if the mother has taken a shower, if there is a birth companion, if she understands what's going to happen, she has a better chance of having a smooth delivery. The fetus has a better chance of having a smooth transition. And let me tell you, now this place in Baroda Medical College where I designed has already delivered 10,000 deliveries. And I invite any one of you to go there. I'm trying to do this in medical college, that there is no one who says push, push, push. This is a tribal belt where there's a lot of teenager pregnancy. Mothers are not depressed. They feel happy. Early skin-to-skin contact has increased. Breastfeeding has increased. Cesarean rate have come down. NICU admissions have come down. This is the study I was talking about, that those who are born between 37 to 39 weeks, 39 to 41 weeks, so a baby's brain at 35 weeks only has 2/3 of what it will weigh at 39 to 40 weeks. Don't interrupt the brain, allow it to form. Can you improve the cognition during pregnancy? So we only talk of IMR, MMR, these are just numbers, but for a mother, it means a birth of a child who is a dream to the mother and would perform much better. So I think now we should, as a Homo sapien, talk about the cognitive development. Now, is this cognitive development all genes? Is it that higher caste versus lower caste? Is it that it is a doctor's child or a Nobel laureate child? He'll become more intelligent. So this brought in the chapter of epigenetics, which says for genes to express, you require an environment. EP means above and above. So with this, if there's a small thing which you can do, the cognition of the child will improve. Just after the birth, don't cut the cord. Keep the child on the mother's skin. There are 9 stages. The first, the child will cry, then he'll relax and awaken, then he'll crawl, then he'll become active, then he'll rest, then he'll familiarize, he will suck, and he'll go to the sleep. These 9 instinctive stages takes about an hour. And we are designing equipments so that instead of having a mother corner and a baby corner, instead of thinking about obstetrics and neonatology as 2 different countries, can we have the overarching one thought process of perinatology, and can we keep the mother and child together instead of having a mother corner and a baby corner? When the mother touches the child, this information goes with a different pathway to a different area of the brain. It goes to insular cortex. Insula means an island. If you remove the 2 lateral sulcuses, you get the hidden emotional cortex. But if the father touches or the doctor touches, then this area goes to the area 312, which is the somatosensory cortex. So you can see the mother's touch cannot be replaced by any other touch. This is again with the beautiful paper which showed that the insular cortex, it grows much better if the mother is close to the baby. Regarding the vaginal delivery and the C-section, I'm afraid the C-section rates are increasing. We think the baby has cried, what's wrong with the child? But long-term studies are showing that there are changes in cognition, there are changes in the C-section birth microbiome, and there's inflammatory immune regulators. So if C-section delivery is the need of the commercial need, I think it is better to make the normal delivery as costly as the C-section. But epigenetics is with normal delivery and not with C-section. The microglial associated remodeling is much better with vaginal birth as compared with the C-section birth. And if you don't believe it, there's a beautiful study which did a MRI and did a diffuse tensor imaging, which analyzes the tract-based spatial statistics. And they found that with C-section, the task-based understanding is less as compared to the vaginal delivery. And this what you call the DMN connection, the independent component analysis of the fMRI, shows that if you tell a child to perform some action in the absence of a stimulus, then the normal delivery child will still perform that task, but it will not be possible for the C-section. For the C-section, you have to repeat that task plenty of times before the child learns how to do it. The birth defect screening, which was developed in RBSK, must be done. So this is an important paper to show how do we improve the epigenetics? So breastfeeding improves epigenetics, normal delivery improves epigenetics, keeping the mother and child improves, uh, rushing through the delivery uh, is a negative factor for, and it causes a dysbiosis. Uh, One very important thing is that sleep influences a baby's cognitive and language skills. I'm afraid both within the hospital and outside the hospital, every day in Calcutta you can see that there's some festival and they will put a loud audio noise and would like to enjoy, whether it is some cricket game which some country has won or a football game. Noise is something which we want is synonymous with celebration. But if there is a baby around in the house, either in the hospital or outside the hospital, this baby's brain is getting impacted because you require sleep. If you still don't believe me, in United Kingdom, planes are not allowed to land during the night because it would impact the sleep influences. And India, uh, to earn more money, allows more plane to land at night. If you see a brain at 23 weeks, it's all smooth, and by 40 weeks, it is all complex gyrations. And in the first 12 months, it gains about 12 centimeter. So just to tell all of you that 100 billion neurons are formed in 40 weeks, 240,000 neurons per minute. And after the birth, 700 neural connections happen every second. So if you think that Oxford and Cambridge's make brain, English medium schools make brain, I think I would like to differ. Biology teaches you it is the first 6 years of life which forms 90% of the brain, and the brain formation is at its zenith in the last trimester and the first 2 years of life. We were talking about deliveries. We were talking about that at NRS Medical College, we have midwifery delivery. Now, this midwifery word has to be also understood. In India, we had dyes delivering it. And this is a wonderful paper which show a news report which shows untouchable after birth. Uttarakhand's new mother are left in stressful isolation. This is not in Uttarakhand. This happens in Bengal also. This happens in Kerala also. So with all our literacy, we consider the woman to be impure at 3 times. 1, during menses. 2, at the birth of the child. And 3, if someone dies. Now, the traditionalist may argue that this seclusion allows the new mother time to rest. But this is a wrong statement. So what is exactly said that even when the modern medical science had not entered India, they were Buddhi or Vads, they would not touch a pregnant woman because the pregnant woman was untouchable. So she was allowed to be touched by another untouchable, and that was a Dai who would not be invited for any festival of the child, not even the child's marriage, but at the only time she would be invited was when there was a birth of a child, and this mother would be secluded. Nowadays, we talk about a lot of things. So this concept of a Dai delivery has not even moved from modern medical science. If you enter any labor room, either in government or private sector, you will find that the person who is attending it is either an intern or the lowest rung of knowledge person is there, and she or he will be shouting. Rarely have I seen professors entering. Doctors prefer to do C-sections rather than to do normal deliveries and improve the cognition. We do not have enough time for the mother. We have never thought to design the labor room for the mother. And if complete it, now we talk about Ram, but Tulsidas, who was born, he was born with natal teeth. His father was Atma Ram Dubey and his mother was Hulsi Devi. He was born in present day Gonda, UP. both the parents wanted to kill their child because they thought that this child is basically a Rakshas because he has teeth, and so he will kill us if we don't kill him. Incidentally, the Dai who delivered Tulsidas took pity and said, I am an untouchable. This child will never enter your area. I will bring up the child. So this Munni Bai takes her to her village in Hariharpur, and till Tulsidas was 5 years, she protected. But after that, she died because of old age. Now, this is the time when Tulsidas was not given any food. He was an orphan. He was maltreated till a Brahmin from Varanasi came and picked him up and educated him. So you can see that how a child's dogma is still there. So those who are talking about Ram Janmabhoomi and Ram, they are forgetting that Tulsidas in his own life had to suffer, and this orthodox, this belief has not changed. So bringing in midwifery is not the solution. We will have to think in a new way, a renaissance in our thought process regarding the mother and the child. Some of this I had the chance at AIIMS to do my experiment. So when I found that even a ventilated baby, if the mother was kept next to the baby, then their cognition was better, their sepsis rate came down, and their overall discharge rate from the hospital improved. I thought I had expected the opposite, because these mothers then can cause more infection. So what was the change? And I found every mother, even if she is not educated, any resident who would go near the child, she would tell him, please, can you wash your hand? If some resident would like to prick the child, she would say, my child has just gone off to sleep. Can you wait for some time? This protection of REM sleep was the one which protected the cognition. This is, we are told the child should not be given a bath, but every preterm child is taking a bath in the mother's womb. I found that solution was similar to ringalactate. I found the temperature, and we are sitting in Tropic of Cancer and Tropic of Capricorn. How can we follow the European guidelines which are developed close to Arctic and Antarctic? So a lot of experiments can be done, but most important is I will take 30 seconds for all of you to just understand. This uterine artery, which is bringing oxygenated blood to the baby, remember, oxygen is required to produce ATP, and ATP is required by the brain. So the uterine artery from the mother's side passing through the myometrium is taking oxygen at 100 millimeter of mercury at pressure, and the uterine vein which is returning has 40 millimeter of mercury. So 60 millimeter of mercury is getting dissolved in a lake which is known as the chorionic. From the fetal side, the umbilical artery is bringing the deoxygenated blood with a pressure of partial pressure of 20 millimeter of mercury, and it takes some oxygen, and so the umbilical vein is taking 30 millimeter of mercury. This is entirely just like the lung, the exchange taking place. Now when the child is about to be born, the mother says to the child, I have kept the cord 40 centimeter. So when you go out and you require to breathe for the first time, you want to breathe air. Don't cut the cord. Not delayed cord cutting. Don't cut the cord at all. Till you establish your respiration, which is going to take time, I will support you from my uterine artery, the oxygenated blood through the umbilical vein, not the artery, till your respiration gets established. So in the Jarva tribe, they would cut the cord after the placenta would come out, because that means there is no supply. If the baby is not breathing, then you keep the cord intact and you resuscitate, because the oxygen which is coming to the baby is dissolved oxygen, and the oxygen which you'll give through the ambu bag or ventilator will only go up to the alveoli and still has to diffuse. So the point I'm trying to make is, if we change the design of the labor room, we will be using less synthetic oxytocin. The natural oxytocin contracts the uterine artery, but it is pulsatile, so it immediately relieves it. So there is no lack of oxygenation. There is a gap of only 60 seconds where the oxygen is already dissolved in the lake. It is like pinching your nose beyond, but when you use synthetic oxytocin, you give continuous. And so the uterine artery can undergo spasm for a longer period of time. And these are wonderful papers which shows effect of intrapartum oxytocin on neonatal encephalopathy or brain damage, and augmentation of labor associated with increased emergency C-section. Up till that it is okay, but more neonatal death and more birth asphyxia. So I did an experiment to show that if you delay the cord clamping until placental delivery, not 1 minute or 2 minutes, because it is the mother and the child decides. So whenever the child will start breathing, the child will send a signal to the mother, the placenta will leave and no more oxygenation. But if the baby takes 3 minutes, 4 minutes to breathe, this oxygen supply from the placenta will keep on. And that is why the distance from the uterus to the outside is 40 centimeters. So when I did this study, we found that there was 8% more oxygenation going to this. The same study was repeated by Dr. Narayan Jana at Seva Sadan, and he got almost the same results. When we did the study that, okay, this is a randomized control trial with 3-arm study, the blue line is physiological. That means whenever the placenta comes out, we are going to cut the cord. The green line is at 3 minutes, and the yellow line is at 2 minutes. When we measured the oxygen of the baby, we found that physiological cord clamping was at least 10% more higher, and by 5 minutes could touch almost 90%. Whereas if you cut after 1 minute. Now we are doing a long-term study to show the cognitive difference. We have also been able to design, and I've given it to the medical college, this is a patented, that without cord cutting, we can make this instrument go next to the mother, and the baby can be treated by keeping the cord intact, which means it will get oxygen from both the sides. These are the designs. I will try to end this by showing what is a physiological cord clamping. Now this baby's head is formed. Head is out. Usually by this time the baby has not cried. Someone would have pulled the head. See the rotation. It has rotated on its own. The shoulder has come out. The baby has not cried. How is the oxygen going? It is going by the cord. No one is telling the mother to push. No one is pulling out the child. You are waiting. There is no hurry because the cord is intact. You heard the first cry. This was being demonstrated at Baroda Medical College. The baby has come out on its own. So you can see we didn't cut the cord. We kept the baby on the mother's chest. She was relaxed. And then even for the placenta, we didn't pull the placenta. Because the baby is on the mother's chest, the natural oxytocin will get stimulated. The breastfeeding, mother is relaxed. The cord is not cut. So you can see the placenta is slowly coming out. Please respect the nature. As doctor, we are only required to interact when there's something wrong with the nature. We did also some more studies about the heart rate, ECG. I'm not going to go into that. We have developed a tool by which we can get the heart rate even without cutting the cord. I just like to show you this video. There were 2 ICUs which we made. One in which the mother and the baby will be together. This is not KMC. All babies are with the mother. The mother's bed is next to it. This is a mother NICU. This I could develop with great degree of difficulty because they wanted the mother can come in, but they should go. Mother's bed should not be there. There was another NICU next to this where the mothers were coming and going. So when we compared in the preterm the effect of mother newborn diad level 3 NICU with the conventional level 3 NICU, we wanted to see the neonatal head growth velocity, mortality, morbidity, and neonatal sepsis. And we found that in the mother NICU, the mean gain was 7.4 centimeter as compared to the conventional Western NICU, it was only 5.7 centimeter. There was a decrease in birth sepsis rate. There was much higher chance of survival. So this tells us that there are interventions which can improve the newborn cognition. This I learned from South India, that whenever there was a sick baby and you created this mother's sari and you tied it up and you placed the child inside, the baby would immediately relax. I was very surprised, but my own studies showed that all these warmers in which we keep the child flat is not physiological, because if you kindly see this, it looks very much like the uterus. And so we are now designing a place where such a thing can be designed and it can have the smell of the mother. So just a few words. If you give toys which are violent, through the mirror neuron you are stimulating violence in the society. But if you give a mother duck with children, the child will understand that this is a baby duck and this is a mother duck. If you buy walkers, it produces accident. If you buy this kind of walkers, it helps in child walking. This is Jamini Raya painting where the mother is looking into the eye. The mother is bringing the rocking. So it's a vestibular stimulation, ocular stimulation. She's singing to the baby. The baby comes close to the chest, so can smell, can feel the heartbeat. So the power of play is very important. But this is not the end of the journey. After this, you have to create a model early intervention center where the optometrist, audiologist, pediatrologist, therapist, technician, prosthetist, all would come together so that the cognition is complete. And this is what I had done at my AIIMS before I resigned from there. This is a dental chair. And these were the kind of children which you used to get. And you can see the EEG. So I conclude a very famous line by Amrita Pritham, and she wrote about the partition. So she says, "Oh Waris Shah, I ask you to speak from your grave. Please speak. This partition has brought in so much of misery to the baby who is born, to the mother who is going to deliver. Can you speak from the grave and turn over a page of book of love? Because this land has irrigated with poison." Thank you very much.
Thank you, sir, for your excellent presentation. So we were really mesmerized to hear from you regarding the way you have presented and with the complex scientific things blending with the ancient age Indian practices as well as respecting the mother nature. So I think this is the uh, lesson from the day that how we should proceed for a future uh, neonatal and early newborn care. So thank you once again to both our respected speakers. So we have really enriched. So before conclude, I want to uh, call Sunila Garg Madam, who is a chairperson of Indian Academy of Public Health, to say the way forward and her concluding remarks. Ma'am, please.
Thank you so much, Dr. Dev. And it was really, I'll say very, very, I'll say apt for IPHA to have this talk basically from two very, very eminent speakers, Dr. Amrita Roy and Dr. Arun Kumar Singh. I feel that every word of you, what said Dr. Singh, took me back to 79, 80 when we were, I was practicing as a young house surgeon at Mahatma Gandhi Institute of Medical Sciences. It was really, very amazing. And you took me back to those areas. How much you are close to Mother Nature, that part becomes very, very important. Now, the message to my young fellow colleagues and my students and to our faculty members, my colleagues, Dr. Sangmitra, Dr. Kaushik, and all the, IPHA members I would like to give is that today, when we are talking about that we must have a healthy beginning and a hopeful future, this call was given long back. And this is where we need to go back to our originals and we need to focus upon that how do we strengthen our public accountability. That is one thing which is very, very important. It's not that we subject everyone to cesarean sections. That part is very important. How close is or how important is to have natural delivery, wait and watch, we used to say. That part is very important. We have to have, and I was listening to you, Dr. Arun, that when you talked about, we have to promote, skilled midwifery care. That part and the Ahmedabad example is very close to my heart because we have to, have the natural belief in our natural principles. So birth should be all about health. That part is important. And simultaneously, preconceptual care is also very important. And my dear young students, you have to understand, when we talk about not only fetus or first 1,000 days and all that, we should not forget our young adolescent girls, and preconceptional care equally is very, very important. And that part, we need to, keep in our mind. Because when we talk about continuum of care, it is not only from pediatrics to geriatrics, it also has to include all the components, before even the mother becomes pregnant. That part becomes very important. And there comes the role of implementation research. I've been particularly involved in one of the projects which is being carried out in Navi Mumbai, where we are, mainly dealing with the tribal population. And remember, there is no concept, of marriage over there. But then we need to still talk about that every adolescent girl has got to be healthy. So ultimately, I like to focus on that we need to have, our existing systems are there where we need to make them very strong in terms of providing good leadership and governance. Like Dr. Arun Singh, when I was listening to you, and Dr. Amita, I listened to you as well. And I feel that, it is so important to provide good leadership and governance, and that will not come without science. So that part is very important. And along with that, the capacity building of our healthcare professionals and simultaneously capacity building of our, doctors time, when we talk of young public health professionals or senior public health professionals, it is very important to focus on that. And simultaneously, it is important to have supply chain. It has not got to be very, very sophisticated, but when I was listening to design of labor rooms and all that, that part becomes very important. So that is another part of it. But simultaneously, we need to see that we need to document each and every delivery is very unique. So that part becomes very important. Please see that it is a wait and watch process, which we need to keep on, keep in our mind. Because when we are going to talk about healthy beginning, we ourselves should not be in a hurry. That part is very important. And wait and watch has to be the option. And then only we can have hopeful future with the help of, a healthy mother, having focused on first 1,000 days, focusing on nutrition, immunization, and all that. Another thing is that we need to also address the issue of inequality, and gender part becomes very, very important, because when we talk of, MMR today of 97 per 100,000, live births, or when we talk of neonatal mortality rate of 20 per 1,000, births. So that part we have to also keep in mind. So please remember that today when we are talking, it's not only from the perspective of pediatrician or obstetrician, but from the perspective of integrating all the associations together. So this is where, the key thing is that follow multidisciplinary approach. Even a humble, I'll say paramedical worker or a DAI or a person who is conducting the delivery teaches us a lot. That part, because have faith in our own traditional systems, that part becomes very, very important. So I would like to, conclude by that, basically that we need to have not only celebration for this 1 year, but it is celebration throughout, which has very, very important. And we do have this RMNCHA as one of the important task forces at Ayushman Arogya Mandir level, along with the other, task forces. We have 12 task forces which are addressing all issues from pediatrics to geriatrics. And now we are talking of cancer survivorship, because now we know that, expectancy of life for female is 72 years and for male is 70 years. But we have to make sure that women are also not only better biological survivors, but also good social survivors. So that part becomes very, very important. And I also congratulate simultaneously being a National Task Force member for, NACO, which is addressing the issue of HIV, AIDS, and syphilis and all that. I congratulate all my colleagues for bringing out a joint paper on, HIV, syphilis, along with hepatitis B. So we need to, keep our systems in mind. And I will say that key things which were very, very important, apart from your normal delivery process and all this, that when focus on, the routine processes, dental hygiene becomes very, very important. And even children, young children are at risk of, acquiring rabies, caries and all that. So that part becomes very important. So with all this, I'll say that have faith in your systems, document everything properly. We are, still miles apart from achieving the national, sustainable development goal. So all the best to all my colleagues of IPHA for organizing such a wonderful seminar, and congratulations to both the speakers, Dr. Amita Roy and Professor Arun Kumar Singh. Your talks have been really, really very, very enlightening, and I'm sure it will pave a path for our, association in future as well. Thank you so much. Thank you.
Thank you, ma'am. So to conclude, I just want to give my sincere thanks to both the speakers and the President and Secretary General of our organization, and all the esteemed guests who have joined into this webinar to celebrate the World Health Day by Indian Public Health Association. And last but not the least, the people who are behind the scene, like our office BRS, like Shobhik and Dipanita, who have worked a lot since morning to make it a successful one. So thank you all. So stay safe, stay healthy.
Thank you.
Thank you.
Thank you all.